Well, thank you everyone for having me here. I've been with this program now for a little over 1 year as an independent consultant and advising the CTNB1 Foundation and the whole team on setting up the biodistribution and the toxicology studies. And for that capacity, I'm also here talking today. When I boarded yesterday my plane in Amsterdam, I wasn't really sure what I was going to tell you today because I didn't have any data to show you today. However, during my flight, well, which I found out when I landed, of course, I saw some emails coming in. So I've got some really preliminary data on the biodistribution yesterday afternoon, which I also included in my presentation, at least a small part of it. But taking a step back first of all, I stand over here. Would like to talk to you a little bit about what we mean with biodistribution and what it actually is. So a biodistribution study is actually a study where we look at how a drug travels through the body, to which organs it goes. I think this is my old presentation, not my updated one. Can we change this? That would be, yes, last night. To Lavra, I think. Yeah.
Okay, yeah. In the meantime, if someone has any questions for Dr. Lezek or Andrea, I would be very happy to answer. Like, I'll be very happy to ask them. Yeah, but we have time. That's why I thought. Anyone? Researchers, parents? Yes.
How effective has getting government involvement for funding been? Sure, any governments, yes. I mean, the way that I look at it is your slide shows that this affects a lot of people. So it seems like there should be a lot of government interest in solving these. Okay, thank you.
Thank you.
Hi there. I'm always scared when I'm about to ask a question because I don't really know what I'm saying. But just to check if I had got you right, you said that if children have antibodies for this vector, the chosen one won't be suitable for this kind of therapy. That's what I understood. And I understand that this is a very typical virus, so it might, reduce the amount of possibilities, isn't it?
We give into the for example, Zolgensma is given into the bloodstream and the antibodies are in the blood, so it's very reactive. If you go in a direct brain administration, you still want to check, but the impact of the antibodies will be significantly lower. So it is still something it's going to be checked, but I'm not sure if what was the level that was. Yeah, it is an exclusion. Yeah. So Zolgensma was the same way. So in the first clinical trial, it's an exclusion, but after that, it's not necessarily. Because I know it's maybe doesn't sound very good, but the way you have to think about the clinical trial is if you don't pick the patients correctly and carefully, the conclusion might be that it's not working. Actually, it is working, but maybe not for, and if you make that bad decision, let's just say that way, this whole story would be stopped. So you want to selectively pick the patients to convince the government and yourself that this is working, and then you expand into other patients. So the first one is the most difficult, The decisions are very tough, but they are for good reason. They're really to increase the chance that this is going to continue forward.
So thank you. I'll take the questions afterwards in the roundtable because we are good to go. The stage is yours.
Yeah, thank you. So to continue, a biodistribution study studies how a drug travels through the body after being dosed. And this can be anything from a larger or structure to the smallest structures of the body. So we study how it goes from the organs to the tissues within the organs, and then also to see which cell types are affected. And then you could even go up to study it within the cell, where it goes in the cell. And not only where it goes, but also how and when the body gets rid of it. So what can all affect biodistribution of a drug? Well, first of all, the location of the dosing. You see here this nice little red on my slide, and all the arrows point to locations where you can dose a rat. And you maybe appreciate that it's much different how a drug would travel through a body when the drug enters through your mouth into the stomach and then goes to the intestines, or whether you inject it into the brain itself or directly into the bloodstream. Another thing that can affect biodistribution is simple physical size and shape. How large a drug is, how small it is, the form of the drug. That can already have implications on how and how fast a drug can move within the body. Digging a little bit deeper, we have physical chemical properties. So each drug has some properties, saying solubility, stability. Does it stay together as one entity? Does it fall apart? Is it lipophilic? So does it want to be into cells, or is it more water soluble? So it actually does not want to go into cells that much. It cannot cross the lipid layer that easily. And there are a lot of more of these factors around. Then the final big component of biodistribution is also metabolism and drug clearance. When you take a drug, any type of drug, the body wants to get rid of it, actually. So that means it's doing everything to get rid of your drug. Major components there are the liver and the kidney, who try to get rid of any drug that enters your body, but especially also for gene therapy. As Leszek already alluded to, antibodies are also an important source where the antibodies would already recognize the vectors attached to it and give a signal that the body should get rid of this very fast. There are much more particular effects that can affect biodistribution, but I will not go into this today. But it's good to understand and to think of biodistribution that this is not something static. It's not something that you measure once and you're done. Something that you follow over time. When the drug comes in, does something in your body, but also eventually will get out. And depending on the type of drug, that can be really fast in a few hours, or it can be weeks or months. So why do we want to study this? Of course, it's all very nice from a scientific point of view, but the important thing is that it provides context for the evaluation of our other pharmacology and toxicology studies. Because we want to know where this drug has been, and if we see an effect in a particular organ, we will also want to know, was the drug even there or not? Because that has a different implication on whether we have maybe a direct or indirect effect, or whether this is something sporadic at all. So we want to know which organs were exposed to the drug, which cell types in these organs may be affected, how long a treatment stays there, and then match this up to the findings of our other studies. And especially for AAV9 delivery, we also want to observe and compare RNA expression to see, has the drug not only been delivered to a compartment, but has it also produces its effect. And understanding this all together with the other data we collect it makes us to be able to evaluate better the patient risk and the benefits for them for a clinical trial. But it's also a regulatory requirement as such. And the regulatory framework for biodistribution studies is the ICH S12 guideline. which is a guideline that requests evaluation of the gene therapy product at the site of administration and in target and non-target tissues. And it's in vivo biodistribution, so you need to show this in vivo in an animal model. You need to show, investigate persistence, so how long does it stay there, when will it get out, and also the clearance there, which holds a resemblance to it. And this guideline is not only saying, yeah, you have to do this, but it also gives you a lot of guidance on how to set up these type of studies, which organs you should examine, which are more and less critical, and the expected quality standards on the analysis of it. So focusing a little bit in on Urbagen, so the biodistribution starts here with the dose route selection. So a lot of therapies are given intravenous, but here we are looking at the cerebroventricular dosing. And why do people give intravenous injections? Well, you can have a very swift distribution to highly perfused organs like the heart, the liver, the kidneys. The brain is also very highly perfused, although it's been protected by a blood-brain barrier. Not all AAVs can pass that, mostly cannot. AAV9 can be in some extent, but you lose a lot of drug by going through that route. Also, when you go via the intravenous route, the drug will be very accessible to drug metabolism and potential anti-drug antibodies. When you go the intracerebroventricular route, you go directly to the location where you want the drug to act. So in this case, the brain, and you have a delayed distribution to the other organs in the body. And also the brain compartment is less accessible to drug metabolism and anti-drug antibodies. So giving you a better chance at giving an efficacious dose, and maybe also at a reduced dose level. We have already a general understanding on the AAV9 distribution profile, both in humans and in animals. And we know that it has the tendency to distribute to some organs a little bit more than others. For instance, the brain, the liver, and the skeletal muscles are targets for AAV9. We also see some discrepancies between species. On the right side, you have some mouse data for AAV9 distribution from the literature. And there you see, for instance, that in the mouse, you also see a very large portion going to the gastrointestinal tract, which is not really the case for all of the species. So that's an important caveat to realize when you're talking about biodistribution, you have species differences. A rat is not a monkey and is certainly not our children. And the good thing of AAV9, which we use for Urbagen, is that it has a very broad tissue tropism across species. So that means that a lot of the same organs are affected between, we hypothesize a lot of the same organs are affected between species, but we have to consider this is not completely the same. And also we have to consider that the drug volume that we inject does not fully scale with the different anatomical size of the animals. So we need to correct for that and calculate that as well. And there are also some other anatomical and physiological differences that we always need to keep into account. So what studies did we conduct for the Urbagen program on biodistribution? So we did a 1-month biodistribution study only after single ICV dose. We also did a 3-month with a 6 or 9-month, still to be decided, biodistribution in the mouse after a single ICV dose. And we had a 3-month biodistribution follow-up in the non-human primate after ICV, both unilateral or bilateral or internal cister magna dosing. And then we had all the analytics that go with this. So in our studies, both the DNA and the RNA biodistribution will be measured. So that means that we have the vector DNA where we can show where the full drug is going in the body, but we also can measure the RNA, which shows us if the drug is actually acted in each of the organs. So going now about some of the preliminary results. First, a status update on the analytical method development and the study measurements. So where are we? For the mouse, we have fully completed the DNA isolation protocol, and the DNA method development is completely done. So this can now run in sort of production mode where we can start screening all of the study samples. And the 1-month study data DNA has been already screened and reported. And for the RNA method, we still need to start the method development in the mouse. And the non-human primate, we are still some issues with optimizing the DNA RNA isolation protocol in some of the tissues, and also the RNA, the method development is still being optimized and some things tested, especially for the RNA method development in the non-human primate. The sequence of the CTNNB1 in monkey and humans is very comparable, and that means that analytical is very difficult to start separating the in the organs to separate, okay, what is normal non-human primate CTNNB1 and what is actually the CTNNB1 that we introduced additionally into that. So analytically, that is a challenge, and they are still optimizing that to get better results. Nevertheless, we received also yesterday some initial results on the 3-month RNA data, but we expect that to be that need to be reviewed a little bit more carefully. So here to show the first month biodistribution studies for the DNA in the mouse. So on this graph, you have on the y-axis, you have the copies of the CTNNB1, the human CTNNB1 gene per microgram of genomic DNA. And then we have all the different tissues. And what you might already see directly, and when you go a little bit to the right, is that you see, okay, well, we dosed in the brain. Why do we see all this expression in the peripheral tissues like the heart, the lung, the liver, and the spleen? Well, this is a readout 1 month after dosing. So that means that in this time frame, the dose has already traveled from the brain compartment only to the peripheral body, and shows that eventually what we dose in the brain will get everywhere in the body over time. Also shows us that after 1 month, the drug is still in there and it's not completely cleared yet. What it also tells us is that in general, we see within each tissue a dose-related trend from our low dose that we dosed up to our high dose. So that gives us also a response, some confidence that we can model our dose levels with the biodistribution. And our 3 months and later follow-up time points will show these same graphs, but then likely the amount of copies will go down until eventually the drug itself has cleared the body fully. So what's the impact of these findings so now on the program? So the biodistribution results, they do show a widespread DNA presence in mouse tissues, which is not unexpected. And together with the 3-month data, will assist in the final interpretation of the 3 months toxicology studies. And also very important is that the non-human primate RNA data that will come in or has come in already, together with the mouse RNA data that Andrea just showed you also, will be also crucial in setting a clinical first dose for the clinical trial. It gives you confidence on where you are with your effect and how if the dose that we will select it, if it has what the chances that we get these similar effects as we have observed in the mice, that we are in the same range. Persistence, the regulatory requirement there is still under evaluation and is depending on the 3 months and 6 and 9 months data. And depending on the outcome there may have an impact on the requested follow-up time in the clinic by the health authorities. With that, I want to wrap up for today. I hope I've given you a little bit of sense of what biodistribution means in the context of a pharmacology and a developmental toxicology study. The results can be informative, not only to understand the results from the studies themselves, but also towards the dose setting of the clinical trial designs. And for Ubergen, the dose route and the technologies selected are aimed at optimizing the local delivery and the initial delivery to the brain to get the maximum effect of the drug there where we want it. And with that, I want to give back the floor.